So lovely to meet you from the Centre for Health Profession Education. A lot of the work that I do is for all professions, and this presentation today will also be of relevance to all professions. So welcome, and it's good to be here. I'll be very quick with the first two slides because I have shown people before, but for the benefit of new people, I come from Australia, and I come from Swinburne University that sits on the lands of the Wurundjeri people from the Kulin Nation. They're the traditional owners of that land that have been there. And I also like to really thank and give acknowledgement to the University of Parma and the people that have brought me here. Antonio, Mario, others that have helped me. So thank you very much for that. I am New Zealand born and an Australian as well, so I'm a Kiwi Aussie, and first a nurse and midwife, and over the years I've worked, taught and researched nationally and internationally across Australia, New Zealand, East Africa, Asia, UK, other places, and have a real focus on interprofessional education, collaborative care, patient-centred care, and also regional development and capacity building. So that's just a little bit about me. Today, I've been asked to talk to you about competency-based curricula and OSCE assessments. So I've been talking to Antonio a little, and you have elements of competency-based curriculum, and you have elements of OSCE. So hopefully today's presentation may just add a few little extra tips for your understanding, so that that's helpful in the work that you do. So first of all, to what extent is your curriculum competency-based, and what information would be most helpful to you today about competency-based curricula? Feel free to interact and ask me questions if you think that there's something you really want to know that would be helpful. Kind of what assessment processes do you currently use and to assess the competencies of your students? And there's many ways of doing that. And if you are using OSCE, what would be most helpful for your ongoing development? These are questions for you to consider as we talk about today. So is it most helpful to think about the setup of your labs and your simulation centre? And I've got some information about that. About writing scenarios, that's a skill in itself. Preparing students for assessment, mock OSCEs, tips for examiners, how are you examining, and anything else that may come to light. So I'm going to go over some of those things today, and the things that you might find most helpful or would like to know most about, just feel free to give the questions. Also, if you would like a copy of this, we'll give you a full copy afterwards of this and the attached documents. So basically, a competency-based curriculum starts with the definitions of the competencies. It's a plan, it's a map. It says, what do you want people to be able to do at the end of a course? And then how are you going to assess those things, and how you're going to design the instructions for how you're going to assess them, and how you're going to implement and evaluate those. So you need to be able to go through those basic steps to consider that you've actually got a competency-based curriculum, which is, as I've just summarised, a written plan to produce your nursing or your health professional graduates. It's your plan. And when your accrediting authorities come and have a look at you, they say, we want to see your curriculum, we want to see your pieces of paper, we want to see what you plan to do. It provides written evidence of all your relevant activities, your resources, your processes and your procedures. It justifies what is taught and how you're going to teach it. And it should detail the expected competencies. And that's the difference between a competency-based curricula and some other more traditional earlier curricula, that the competency-based ones very clearly says, this is what we want your students to do, and this is the level of competency at year 1, 2, and 3. And it also details how you're going to assess those competencies. So again, this is another way of looking at it. It's a program of learning, your broad descriptions of what you've got, your graduate profile, your competencies, and graduates who are competent across each of your domains. So those competency domains, and we'll look at those in another slide in a minute. And then that's the broad curriculum, and then that comes down to each course. In each course, you have your learning outcomes and much more specific information about your content, your delivery, and assessment for each course. And again, really defining what competencies that you will have for your students and how. And quite often, these kind of pictures that I'm showing you at the moment is quite good to put right up front in your competency documents so that those that read it, your tutors, the accrediting authority, the people at the hospital, can actually see how it's structured and it makes sense of how it goes along. So typically, you've got your scope of nursing practice or your scope of health professional practice. So basically at the side, it's got the scope of, this is what a nurse can do, this is what a doctor can do, this is what a physiotherapist can do, and those often come from your regulatory authority, right? And then that you always need to situate that inside a context, in a context. So for example, I work for Griffith University in Australia, right? And the people of the United Arab Emirates, the leaders, they purchased the Griffith curriculum and they purchased services of a head of school like myself to go there and put the curriculum and help them start nursing programs. But like there's things in a Griffith and an Australian curriculum that don't fit the context, right? It's not serving an Arabic speaking country. It's not serving a Muslim speaking country, and it's about Aboriginal Australia, it's about multicultural Australia. So your curriculum has many things that are common, doesn't matter where it is in the world, but it has to be situated and cited in the context of Italy or the local language, the local customs, the local health system, etc. And then there's the competencies. So mainly, and these go right across health professionals, all health professionals, there's the scientific evidence that's underpinning either nursing practice, physio practice, medical practice. There's the management routine and contingency things. There's things about innovation and critical thinking, therapeutic communication, collaboration and partnership, ethical and legal context, your lifelong learning, and things about professionalism. So there's these things that are kind of just globally generic, really, and those are the competencies, and those are the competencies that we talk about. How do you actually develop those competencies and assess them throughout the course of your training program? So when you're assessing competencies, you also need to think about the level that you're expecting, right? So if you're thinking about basic communication skills, or you're thinking about critical thinking skills, are you assessing a novice nurse in her first, or a novice health professional in the first few weeks and first 6 months of their program, to an advanced beginner, someone who's competent, somebody that's proficient, and someone that's expert? Now, in your first year, you're really looking at a novice. Second year, kind of an advanced beginner, and you would hope that what you graduate is somebody competent to practice. And basically what we mean by competent to practice is, are they safe? Can you give them a license to practice nursing or practice medicine and be confident? Yes, they're not yet proficient and they're not yet expert. They're not a nurse practitioner. They're not a ward charge nurse. They're not a leader of a health service, but are they safe to practice? So the purpose of you really, and we're going to talk a little bit about today, the purpose about OSCEs is that we're going to talk about how do you design an OSCE to try and ascertain safety to practice, because that's the core of our responsibility. So OSCE now is basically a really globally accepted tool, and even if you are not using them extensively in your program, it is something that you should teach to your nurses and health professionals, because, for example, New Zealand, Australia, other countries, if you migrate and you want to come and practice nursing there, you have to demonstrate that you are competent, and they send you to a national OSCE centre, which can be pretty jolly scary, right? So, and unless you can get past that OSCE, and you have to fly to Australia or fly to Christchurch in New Zealand and physically present and undergo the OSCE experience, you do not get a licence to practice in another country. So it's important for two things. It's important for our students and our accountability as educators to ensure our graduates are competent, but it's also really important because health professionals are probably some of the most globally mobile people that exist. And so many will come across this kind of scenario. So an OSCE is an objective, and the reason it's got to be objective is that it's got defined criteria to actually try and remove the subjectivity. It's structured, and it's clinical, and it's an examination, right? Now you can actually have OSCE, OSCE, and I didn't talk about that today. So, and some people describe an OSCE as, which instead of examination is an assessment, and they use that more as a formative assessment rather than summative. Yeah, and to support students' learnings, they need regular OSCE-orientated lab sessions with detailed formative feedback, and summative prior to the formal summative examination. It's not really fair to suddenly say to a student, well, you've learned all these clinical skills, you've been out on clinical, but before you pass this course, you've got to go and do an OSCE, and they've never done one. That's kind of mean. So mock OSCEs or MOSCEs are valuable as a teaching tool to teach the competence, and it teaches the competence, but it also teaches them about the process and helps takes the scariness out of it for students. So why do we use them? So traditional assessment methods are useful for evaluation of knowledge, but not necessarily of skills-related competence. So, usually, you can give them a test, an assignment, something written, and you're getting what's in their head, but you're not actually seeing what they're doing with their hands, not actually witnessing that they can do it and that you know that they can do it. And clinical skills represent, it's a mix of clinical knowledge and communication, interpersonal and problem-solving skills. So it's a whole mix of things. So quite often OSCEs are defined around stations where someone will just come in and change a dressing or change a catheter bag or remove some stitches, right? Traditionally, those OSCEs are just skill-based rather than looking at what we call an OSCE for an episode of care. And the much more effective OSCEs have a whole episode of care, like 30 minutes of care. And you come in, and during that time, you might have to change the dressing, but you're looking at that. Our second point here, the mix of clinical knowledge, communication, interpersonal skills, and problem solving. You're looking at the totality of their practice and not just the thing that they did, like took them stitches out. Yeah. A structured performance-based competency assessment. It's a unique vehicle for managing and measuring their clinical skills and where they're really at. It's now globally accepted, and as I say, it's used by most Western countries as a way of getting a nursing license or a health professional license. And if it's designed and used correctly, both the OSCE, which is observed clinical assessment, and observed clinical examination, they really improve the preparedness of your students for practice and for safe patient care. So if you're going to do one, make one, and you're going to undertake OSCEs, what are some of the best practice guidelines? And there was a group in Australia, Nolte and Mitchell, etc. They got a large research grant across 3 or 4 universities, and the Australian ARTC, Research and Teaching Council, gave them money to undertake a project to look and develop the best practice guidelines for OSCEs. So it's got these 7 guidelines, and then some other authors have adapted them to 8, but I quite like these 7. So first of all, like, this is not a trick. You're not trying to trick students and make it difficult. You're trying to actually ensure that they're safe to practice. So you choose something and focus on something that's directly related to the delivery of safe patient care, because that's what you're measuring. So you don't do some obscure thing that, yeah, it was kind of taught in the course, but, you know, like, they wouldn't come across very often. And so that's number 2, a focus on practice that's most likely to be relevant in terms of regularly encountered, so that they come soon, right? So it's something that they do every day, like admitting a patient, or checking a patient post-op after surgery, the first post-op check, etc. Something that you can judge on a holistic guide to enhance the rigour of the assessment. And something that's going to require them to perform tasks in an integrated rather than a piecemeal fashion, right? And so again, rather than just the task, something that's about an episode of care. And we'll get to that, and I'll show you an example. For it to be structured and delivered in a manner that directly aligns with what they need to develop in their course, and be appropriately timed. So it has to be timed in the sequence. So if they're a novice in year 1, you're not testing something that's taught in year 3. That's just not fair, and that's not going to work. And something that allows for ongoing practice of integrated clinical assessment and innovation of skills. So those were the 7 things to think about. And what I've done is later on, or actually on the previous slide, it doesn't matter, but on the previous slide, I've got the reference so that you can actually look at the article, right? So then what are the components that make an OSCE? So an OSCE must have a STEM, right? So the STEM has got a description of the patients and the context of care, the task and the role. So you're describing the patient, and then the task, what you want the student to do. You have to have the supporting clinical documents. You have to have resource lists, the feedback criteria to give them afterwards, and the marking criteria. So for it to be complete, you have to have all those other components that you need. And the OSCE STEM describes the patient, their age, their name, their social context, their condition, and their care requirements, right? So here's one. It says administration, the episode of care, the nurse is going to go to the patient and administration of medication by intravenous route, infusion setup, and intravenous antibiotic therapy. So you're the RN running the Royal Flying Doctor Service at Metamora Health Service, and Charlie's a 15-year-old Wakanguru man with non-rheumatic heart disease, currently managed with my bi-monthly IM benzathine penicillin. Right? He arrives at the clinic complaining of a high fever and productive cough. On assessment, you find his skin is hot and dry, he's got a moist cough with green sputum. You listen to his chest, he's got some absent breath sounds over both bases. He's feeling weak and tired. He's using his accessory muscles to aid his breathing. His vital signs are 95/60, pulse of 100, respiratory rate 28. His oxygen sat levels are 94%. He's not very well, right? He's not very well at all, right? And the medical officer requests IV vancomycin. So that's a STEM in terms of that you have your patient there, all right? And then it will tell you what you want. What you want the nurse to do in the 30 minutes that they have available with that patient. Right. So to do that, you need some supporting documents. And again, this becomes context specific. So the nurse is given this, the health professional is given the scenario, and there's the patient, either a dummy or a mock patient or an actor in the bed, right? So what else do you need? You need the supporting document. right? And those supporting documents are usually at the end, and they will depend on your context of care. So your particular hospital, kind of things like your nursing assessment on admission, whether or not you have a chart like that, your falls and risk assessment, your initial pain assessment, mini mental health, mouth assessment, wound assessment chart. So you have a folder there, and the person uses the forms that are relevant to that episode of care. Ongoing care, daily patient records, etc. So all of those things need to be available, but this is a scenario of admission. He's just turned up. What you're going to do. So it's the initial assessment forms that are used and specialist forms. But there's usually a folder with all these forms, and they need to know what to use, right? That's part of the competence. And then there's a resource list of what have you got to have there. The equipment, the drugs, the chart, the personnel, and the examination scoring sheets. So in terms of, for this scenario, you obviously, it was about, she's going to set up an IV, administer some IV antibiotics, etc. So you need to be able to have those things, and you need to have something that's actually taken the vital signs, because of course, that's what the scenario says the patients come in with, but they'll need to check that. So it's making sure you have your props and your resources. And these are kind of just some examples of the competencies that you're testing, right? How they're interpreting data, aseptic techniques, communication, privacy, confidentiality, etc. And then to test that, you have marking guides, and I'm actually going to physically give you out a copy of a marking guide in a few minutes, right? So you need to standardise, because this is the OSCE, so it's observed, clinical and structured. So a standardised scoring criteria. It's got to be fast and easy to mark. Remember that you're the examiner and you're watching what's going on. If it's this complicated thing, you're going to be spending so much time in here and you're going to miss what's happening. You actually can't do it, right? It's got to reflect the student's level, whether it's for a first or a second or third year, and really important to highlight critical safety criteria. And I'll show you about why that's important in a minute. And the choice of how you use it as to whether or not this is a summative or a formative one, and whether it should reflect the course learning objectives and the assessment policies. Everything should match with what you're teaching in your curricula for that particular item. So here's a more complicated scoring sheet. And this is really about the communication, where it's, you know, this is basically like, on one end, they're saying that the student was awkward, right? And the other end is confidence, skills, questioning. So it's important that you can develop these kind of scores, because it's all very well to run it, but you have to have a structured way that you can score and give information to the student to give them feedback. So that there is the one that I've got in front of you, all right? So the reason I wanted to give you a copy is that you can't read it off that, and I tried to kind of copy it last night. Okay. So when you're thinking that this student is coming in, and remember she's got a sick man, she's going to make sure that he doesn't deteriorate quickly, that he needs fluids and IV fluids. She needs to be able to communicate to the doctor. She needs to be able to read the chart of what's done, set up the IV line, and draw up the antibiotic, etc. Now, through all of that, traditionally, people would have maybe just watched and marked that she could draw up the antibiotic, but you're looking at an episode of the whole care. So you're looking at, first of all, the communication, right? And also that there's safety things all along the way. The first thing he or she did they wash their hands? Did they introduce themselves? Did they provide privacy? Did they explain the actions to the patient? Did they actually talk to the patient? Did they look at them? Did they talk to them? And did they make sure that the patient was comfortable, etc. at the end? So you've got there, and whether or not they needed to be prompted on anything. The patient assessment, did they do a pain assessment, check the wounds, appropriate observation, etc. So you can tailor these charts to whatever your scenario is. The medication administration, did they check the official medication time, look at the desired, any adverse actions, prepares the appropriate equipment, checks the written order with the second nurse, and your second examiner can be the one that they can ask to come and check. That big of the checking with, that they do the check, prepare it accurately, etc., all the way through. And then the IV administration, it's got the marks on there, etc. So these are all the preparation of the IV fluid with the correct technique. At the bedside, identifies, is looking for the patient ID. It takes you through every step of the way, right? Now, at the end, there's a kind of a total mark out of 100. Now, you can get somebody that scored 96, 95, 96, but they fail, right? Because what's really important is, see that right at the bottom there, those safety, 8 marks, yeah? Removing equipment, maintains asepsis, and documents, and things like medication errors. So they can get it all right, but they made a major medication error and they actually overdosed the patient times 3. So it doesn't matter how well they did something, right? Or it doesn't matter if they did the whole scenario fine and the critical safety criteria, at 2 or 3 points, they forgot to wash their hands, right? So basically students are instructed at the bottom, failure to achieve critical areas means failure to achieve the OSCE overall. So you might say, well, okay, you might say 70% is going to be okay, that, you think that there's safety to practice, but there are drop-dead scenarios in terms of, and you can go through, so you can put the things in black, like wash his hands, the ones that are bolded, right? And your medication, did they check the medication or did they have the right dose? Or the other thing is they dispose of equipment. I've had a couple of students that have been so nervous and trembling and everything like that, and they're administering something to a patient with Hep C, and the first thing they do is kind of like stick themselves with a needle. It's kind of game over in terms of, there's some basic safety things. So you just pause, and it's really important to teach students this is what are the critical safety to practice. You've got to be talking to your patient, you've got to be maintaining your privacy. If they did not check the patient ID before they gave the medication, some of the things. So I haven't necessarily on this form got the safety marks in the right place, because there's other safety marks dotted all the way through. But it is important that you have a section that's a safety section, right? And it's also important that when you run this, because you want to be watching and you always have 2 examiners, right? Because you can miss things, or you can be sitting at a different angle, or you didn't hear something. So it's important that you have this form, which is actually pretty easy to code and mark, and you code it with a pencil, right? And then you have a 15-minute break between the students that you can complete the form. And you also then have a very, very structured process of how to work with your students to give this back, right? To give the feedback. And they find that the more mock OSCEs you do, the more confident they will be. Now, running OSCEs can be quite resource intensive. So once you've taken them through once or twice, you can actually put them in pairs of 3. One's the chief examiner, one's the second examiner, and one's the student, right? And get them to practice before the real deal. And then you find that they haven't got the jitters near as much when they get to the real deal. And also, if in their careers they want to travel or go to another country, they're not going to be in a situation that the first time in their life they're encountering an OSCE. So, any questions about any of that? And all of these forms, etc. Plus, I've got a form that's got 7 stems, so they'll all be emailed out plus the PowerPoint, so you can have everything, right? So tips for examiners. Well in advance, it's really important to communicate with the lab technician about everything you need. Because remember, we have the components. So if you get to the lab or you get to wherever you're going to do it, and some of the props are missing or some of the forms are missing, it doesn't work very well. And it just gets students agitated and annoyed if there's long delays while you're running around trying to get it all set up. Go beforehand, check your stations that you've got everything that's needed. Make sure as an examiner you're familiarised with the scenario, the content of the station, and with the marking sheet. Check the story and all aspects of the patient or simulated patients before the student arrives. If your student you found that even though you've communicated that your station needs equipment, make sure it can be provided again before the students arrive. And make sure it's all present and correct, that you understand how it functions and how to use it. So one of the things that there's a lot of reasons this is important. First of all, it's professionalism and it's credibility. But in Australia in particular, so when it gets to and you will know what high stakes exams are. So say for a medical school or for a nursing school, and this is the thing that's going to say you're safe to practice or you're not safe to practice. They now, they have video cameras, right? Because when students appeal and say, but I did do that, and the tutor says, no, you didn't, there's a video backup. And where it gets really high stakes, let's say someone's being a doctor, 7 years, house surgeon, cardiac registrar, this is a cardiologist, this is high stakes whether they're going to get specialist conferred or not. You can get all kinds of legal cases. And so it's really critical that, you know, when you've got a student or a legal case mounted, but they didn't have all the equipment, I couldn't do that because something wasn't there. So it's really important. During mockies or you know, when you're trialing, you can say, well, that was a learning experience, we had something missing, and you can fix it, right? But when you get to the real deal, it's really important that you have everything present and that you pre-check that. So students are typically brought to a station by the coordinating examiner and invigilator. The primary examiner will confirm their identity, introduce the student to the co-examiner. Students typically have 10 minutes reading and 30 minutes exam time. Let them start the 10-minute reading time immediately, and don't delay them by reading the instructions to them. It's not your job to do that. And during the exam, provide them with a time reminder. So you can say, we're at halfway point, we're at 15 minutes, and stop the examination as soon as the final bell rings. And some students, quite frankly, have run out of time. They might have the IB up, but they haven't done the drugs yet, or something is missing. They simply ran out of time. The marking sheet that I've given you highlights the competencies critical to safe practice and what will result in a failure. And students need to know what safe practice is. So you'll all be aware of the JCIA 6 International Patient Safety Rules, right? Which are about clinical handover, safe medication, prevention of falls. They breach any of those international patient safety goals, and you've got a problem. Student may have a high overall score, but failed due to a single breach of a safety requirement. And a student with a lower score may pass because they're safe in all of the critical areas. And it's designed to help confirm whether a student is competent and safe to move to the next stage of training or graduation. In Australia, where I am, all students at the end of the semester or during the semester before they go on their next placement, they have to pass an OSCE before they go out to placement. So not just, you know, so it's the OSCEs are actually used for the next stage of their transition out to placement, particularly by year 2, they also have to do a drug calculation test, and they have to, within a minimum of 2 goes, they have to receive 100% accuracy, otherwise they can't go on placement. It's very tough. During the exam, observe and listen carefully. Take brief notes only so you're not distracted from your observation. Complete your notes and marking of students at the end of the exam, and use the 10 to 15 minute break to complete the documentation while it's fresh in your mind. and do not tell or show the student their mark at that point of view, at that point in time. Okay. So the primary examiner, some of this is duplicative, brings the student to the exam room, we've talked about that, introduces them to, explains the exam process. I skipped that slide, somehow I left it in. And the secondary examiner does not make any other comment, does not prompt verbally or non-verbally, and observes and individually marks the exam. So they're the second one. And the second examiner is also the person that can be called upon to be, if they have to administer a drug and they need an RE to check the drug, right? So they can ask the second examiner to do that. So what's expected of you? You do confirm the student's ID, you do treat them politely, you mark them fairly and impartially and let them start and finish on time. Don't turn it into a teaching session, right? Don't give the students verbal or non-verbal feedback as how they're doing, good or bad. No hints, right? Don't let them see your marks, right? Some further do's and don'ts. Be aware of your facial expressions. You've got to be really good at poker, right? Students come out and say, well, she's smiling a lot and nodding. I'm sure I did well, you know. Beware of the verbal hints that can mislead them as it was good. Follow the instructions on the marking scheme and finish the paperwork. And don't waste time. Like they're really timed by excessive introduction. Don't interrupt a student when they're talking. Don't express an opinion to the simulated patient re how the student is doing. Right? And don't look at your mobile. Leave your mobile out if you can. But the only time you've got a mobile and you can actually, it's better to have a clock timer. Yeah. So prompts. These are the acceptable things that you can prompt with. Ask them to explain their rationale for doing this. In explaining this, they may pick up an error. So you might say to them, let me try to think of an example. They kind of lifted the edge of a dressing and then popped it down. And you might say, I noticed you did this. What was your rationale? And they might think, actually, well, I should have looked more carefully rather than just under the edge. But you don't, you just ask them to explain. You ask them, say if they're being really, really slow and they're doing too much patient explanation and things like that, and you're aware and you're anxious about the time, you can say, do you think you're ready to move on? Right? Ask them if they'd like to read the instruction again if they appear stuck. So if they're kind of standing there dithering and everything like that, it's okay to say, do you need to read the instructions again? Okay, those are kind of acceptable prompts. The unacceptable prompts are, have you missed something out? Because that clearly indicates that they have, right? Are you going to recalculate that again? Because you're clearly telling them that they've made an error. So you're giving feedback during the jam, you know, are you going to check that with me? So they've drawn up the medication and they've gone over to the patient and they're giving it and you're saying you're going to check that. So they haven't done that critical step of going getting the second person to check the medication. And non-verbal communication, which is admittedly, it's often unintentional between members of the examiner and student. So, you know, raising your eyebrows, looking at the other examiner, kind of, you know, just got to be careful, okay? And this is the issue of accountability. Your role as a health professional educator or a nurse educator, by allowing a student to pass an OSCE exam, a high-stakes OSCE exam, you're confirming they're competent and safe to progress to the next stage of graduation or the graduate nurse induction program. If you have any doubts about their competence ability to practice safely, you need to indicate that in your marking process. It's a heavy responsibility. It's one of the key responsibilities of educators. We have 3 years with them to teach, to support, to coach, to help, to mentor. We have all of those roles, but at the end of the day, we have an accountability in respect to safe practice. We're individually accountable to the public and to the profession for matters pertaining to quality of nursing care and patient safety. So in the midst of all of that, we're also health professionals with a heart. We've been their teachers, their friends, their coaches, their things. Okay, and this form of examination is increasingly globally accepted. I looked at a thing that students described in OSCE as a legalised form of student torture, right? But despite the anxiety, safety of the public is non-negotiable accountability, and the best way to alleviate student stress is through practice. That's where your mock OSCEs are. And as I say, because they're time intensive to set up, often even in self-directed student time, if you have self-directed student time, put them in groups of 3. Say one's the examiner, one's the second examiner, and one's the student. Get them to rotate, get them to practice lots and lots and give them. That helps reduce anxiety. So when they come to the real deal, it's not the first time that they are doing this. Multiple pre-examen opportunities for practice sessions and OSCEs increase their student competence and confidence. Really helps them, right? And then you've got the block student, the ones that just freezes and says, I'm not good at exams, all right. You can't succumb to the temptation to rescue them because you're accountable for the safe practice. You can't coach them or give them hints or unacceptable prompts, but you can help by saying, would you like to just take a deep breath and reread the instructions and remind them and say, just reread and you've still got 15 minutes left, or just try and calm up, right? Because you do get students like that, it is problems. So the mock OSCEs allow them to practice and refine their skills in a realistic and supportive manner, and provide opportunities. Thank you very much. Our next slide is our final slide, and I'll make sure that I send it over to you. So as again, it allows opportunity for practice and skill development, reduces anxiety, builds confidence, identifies weak areas in a supportive context, so that the student themselves, if they're doing mock OSCEs, can actually find out that, goodness, I'm actually not so good at time management. I'm not so good at my patient communication, right? Or there's some of my safety to practice skills. So it teaches them time managers, it provides formative feedback and prepares both students and examiners for summative OSCE scenarios. So, thank you. That's a little bit of a cook's tour through competency-based curriculum and about OSCE as a mechanism for testing that they're competent. And some of what you need to set it up, some of the do's and don'ts, etc. The slides are fully available. The sample marking sheet, I have other documents that have got a sample of 7 STEM scenarios that you can use, and various other resources, and you're free to have all of those. Thanks. Do I press this and it stops recording?
Ms. Sharon, just a question.
Yes.
I'm wondering, how many students do you have for one section of the examination for girls to dedicate half an hour to each of them? You take a lot of time to complete the examination session.
Basically, it depends how many stations. Typically, I was thinking in the UAE, you would have 8 stations, right? So 8 stations in a clinical lab, right? And you have to be able to have quietness and privacy between them, all right? So for 8 stations, you need 16 examiners, right? And I think that the slide that I left out of there, and I had the duplicate, and I'll fix that afterwards. What we used to do, and you've got 2 sites here, haven't you? You've got somewhere else that you teach nursing?
Well, we manage our examination with 3 sessions, and every one session with 2 teachers. and total of 260 students per year.
Yeah. So, but when you choose your examiners, so in the UAE we had a campus at Al Ain and a campus at Mafraq, right? So we used to bring the tutors from Mafraq to Al Ain. We used to swap the tutors for the day, right? And then we would get a tutor. The second examiner was usually someone that came from the hospital, right? So you actually had a situation where it was really quite independent of someone that kind of didn't really know the tutors. And when you say how long does it take with this half hour, it depends how many stations. If you've got 260 students and you've got 3, and you can run in an 8-hour day, you can run maybe 10 or 12 stations times 3, that's 30, and you've got 2
stations.
Yeah, so if they're 30 sessions, right, and they're half hour, right, and you need a 15-minute break between, right, so 1.25 hours, and you need lunchtime in there. So you start at 8 in the morning, stay through till 5 at night, right? So how many times, you work out how many times you run that examination station, right? And how many tutors, so you've only got 3, it's going to take you a week at least to examine all the students. Yes. Yeah, so we basically, we had an examination a week, and we used to run 8 stations, right? And we would swap the tutors for a week, and we would do that, right? That's for your high stake ones, right? For your mock ones, right, you can condense it a lot more by running one with tutors and then getting the students to, and telling the students how important it is for them to be absolutely structured and objective for each other and not do the cheating, because that's the practice for the real deal, right? So that's why, as I say, it is an intensive form of examination. It will depend on your number of tutors that you have, the number of stations that you have, and like I had a walk around your clinical labs, right? So you need a mock ward or somewhere, or you need rooms where one set that's been examined can't hear the other, because that's not fair. They can't have noise, you know? So the question that you've asked me depends entirely on your resourcing for number of beds, number of tutors, number of students. Yeah? It's a divide.
A lot of materials too.
Yeah, yes. Yes, yeah. So where I come from, we have 4 clinical labs that would have on across 2 campuses that would have 10 to 12 beds in each lab, and each bed is completely outfitted with, you know, things for vital signs, your trolleys, and the lab technician at the end of bed, you know those forms I told you about, which are the forms that you use over in the hospital for pain assessment, patient admission, things like that. They have folders of those with all of those forms in laminated format, and the student says, well, I'll use this form, and then on the wall there's these kind of like these pockets on the wall that's got photocopies of those, and you just get them for the students. So the labs are all set up to be able to do this. Yeah, and students practice, because increasingly, and I was going to ask somebody who was trying to figure out how many class hours and how many practice hours, actual hours out in practice, do students in Australia in a nursing degree. The clinical practice hours are 800. There's 600 in Australia, in the US, right? And in the UK, they're still floating around at 2,300. So there's a lot of this competency for safe practice is it's tested a lot more in the clinical practice setting, whereas the students have a lot more class-based things, and then they do the practice in the clinical labs, and then they're tested like this to make sure that they're safe to practice. Now, in Australia and New Zealand, we have a thing called the Trans-Tasman Reciprocity Agreement. So because I'm a New Zealand registered nurse, Australia's confident in my quality and vice versa, and we can just cross there. But if I come from South Africa, or I come from Sweden, or I produce all of my documents, everything, and they say, yep, you've got your degree, you've got your years of experience, you've got your references, you've got everything like that. Now come down to Christchurch and we're going to put you through 3 OSCEs and we'll test that you're safe to practice. You fly down there at your own expense and you're either safe to practice or you're not. You go home. And it's a high stakes exam. So increasingly students are taught and examined like this during training, and it's got a skill and a technique to it, you know, like you can't run an OSCE and then have prompted the students and kind of given them hints and then say that they're safe to practice, or, you know, there's some of the actual best practice principles that I've gone through, and it's not a trick. So, you know, you let me think, what's a really obscure disorder like genetic haemophilia, like some of the kings and queens of Europe had, right? Okay, so versus rheumatic heart failure or cardiovascular disease or type 2 diabetes, right? So you're testing around the things that are common. It's not a trick to try and write a scenario about inherited medieval hemolytic diseases and give a scenario to a student that they've got no idea about, that they've never seen before, because you give a scenario about the things that are common in their practice because you want to test that they can communicate with the patient, that they can assess the vital signs, that they can pick cues, that they can safely administer a medication, that they can use a aseptic technique to, so this scenario was around safe administration. I've got other scenarios which is basically about the episode of care, the 30 minutes of after a patient comes back from theatre, you know, okay, they've taken their blood pressure, they've looked at them, they've asked about their pain. Did they actually take back the bedclothes? Did they properly look at the dressing site to see whether there was any bleeding or not? You know, so you want your scenarios around the common things for safe practice, because all of this is about a safe practice. That's what you do. You run a nursing course, and at the end of the nursing course, you say, I, the university, am swearing to the public that this person is safe to practice and will not harm you. Not because of lack of competence. Might make a mistake, none of us are perfect, you know, but still, yeah, it's just about that. Okay. Yes.
I don't know if you have covered the safety and effectiveness of practice in your presentation, because I've got distracted, so I couldn't really follow you. But just a couple of questions about what do you think are the most important elements we should include in our OSCE to ensure safety and effectiveness in clinical practice, like, for example, we know how important are medication calculation, or I don't know.
Six things, okay? Yeah. Go to the JCI, Joint Commission International 6 patient safety goals, right? Tattoo those on your eyelids of every student in the place. One of them is prevention of falls. So, for example, you have an elderly patient, the scenario, they're a bit elderly, they've been to theatre and they're a bit confused, okay? So you say to them, and they'd say they've had a hip replacement, right? Common thing, old person fractures their hip. You go in, you're the nurse, right? And you do the post-op vital signs, you check their wound, you check their pain, right? And you pump the bed up so that it's at your height, you can do that. And then when you're finished, you walk away. What international patient safety goal did you just breach? Prevention of patient falls. Did you put the bed right down again so that they get out, they're not going to fall off the edge? So they used to put up bed rails, all right? They don't use bed rails anymore because confused patients climb over the top, and it's even further to fall, right? So that the safety goals that you integrate into your scenarios, and I can try and find you more sheets about this, right? Is basically it's safety and medication safety, particularly your high-risk medications, your opioids and your things like that. Prevention of infection, safe clinical handover, right? Did we safe clinical handover? But and prevention of falls. There's 6 goals, right? But the ones that students will typically miss during OSCE, they do some steps and forget to wash their hands, or they make a medication error, or they do something that's really dumb in terms of when you write your scenario, you think about what safety goal you were looking for, right? So a safety goal that you were looking for is, I say, an elderly patient, a confused patient, or did you basically say to that patient as you're there, did you put the bed right back down after you finish what you're doing so that the patient's close to the floor again? And did you say, for example, I'm just ringing for I think your relative's here to come and sit with you, right? So it's those episodes of prevention of the safety, and they're really common sense things. Yeah.